Welcome, everybody. My name's Jimena Garcia, and I work for Governor Laura Kelly as the Senior Advisor for Vaccine Equity. And I'm so honored to be here to introduce our next speaker, Dr. Jamie Jacobsen. She is a native of Hoyt, Kansas, and a member of the Citizen Potawatomi Nation. She is Medical Director of the Prairie Potawatomi Health Center. She also works part-time as an emergency physician at the University of Kansas St. Francis campus in Topeka, where she worked on the front lines during the COVID-19 pandemic. She earned a Doctor of Chiropractic degree from Cleveland Chiropractic College in Kansas City, worked as a chiropractor in Topeka, and volunteered at the Prairie Potawatomi Health Center. Dr. Jacobsen later earned her Doctor of Osteopathic Medicine degree from Kansas City University, and then completed a family medicine residency through Oklahoma State University. She began fulfilling her Indian Health Services scholarship obligation at the Federal Pawnee Indian Health Center in Pawnee, Oklahoma. She completed the last 3 years of her service obligation at the Kickapoo Nation Health Center outside of Horton, Kansas. And with that, help me welcome Dr. Jacobsen.
Thank you. Good morning, everybody. Welcome. Thank you for coming to my talk about COVID. Hopefully you'll enjoy it. I want to say that I'm really happy to be back in Indian Health and back at the Kansas Tribal Health Summit. When I was the medical physician at the Kickapoo Nation Health Center, I had attended this conference a couple different times and thought it was a really great event. And then I had stepped away from Indian Health for about 4.5 to 5 years to work full-time emergency medicine in Topeka. So I'd been away, and then of course during COVID, the event, was not held. So I was really thrilled when I started back at Prairie Band to learn that the Tribal Health Summit was back up and running and going to be in person, and I would be able to attend this year because I just think it's a great event for collaboration and community building with all the tribes and health centers. So. And thank you, Dr. Garcia, for introducing me. A chance encounter over lunch with Dr. Garcia led to me speaking here today, and I was really honored to be asked to do so. But I'll be honest, I wasn't really honored to be asked to speak about COVID. And in full disclosure, Dr. Garcia had given me the option of what I wanted to talk about. And I said, oh, whatever the board or the committee members feel would be important. And she came back and said, let's talk about COVID. And I said, I don't want to talk about COVID. And actually, I'm tired of COVID. We're all tired of COVID. What else is there to say, about COVID? So I kind of pondered this for a while, and I hope you're not expecting a really scientific lecture about COVID, because this is going to be just a little more talk about my thoughts and some of my experiences working in the front line of COVID-19, being in the emergency department full-time, and what we saw and what we had to deal with there. So, okay, hopefully. All right, my clicker's working. So we'll start off with just a few pictures of myself here that are reflective of the COVID-19 pandemic. So that first picture there on the left was in April of 2020, okay, right when the pandemic started. That's my full personal protective equipment there in the emergency departments. But what most people don't realize seeing that picture is that those were gowns we were having to wipe down every day and reuse. We had to reuse those same gowns for days at a time, wipe them down between patients. Those N95 masks, we had to use those for at least 4 shifts, we were told by hospital administration, because we didn't have enough masks. That face shield that I have was actually my brother-in-law owns a welding company, and when I told him how we weren't having enough masks or protective equipment, he donated a whole box of welding masks. So that's actually a welding mask. But I remember being really thrilled. We were all so excited to get that box of welding masks that we could also wear to further protect ourselves. And I just look at that picture and I think, how scared we all were, like everybody was, but especially those of us in the emergency department. We were scared of this virus, scared of, what it was going to do to our patients, and then scared for ourselves and then our families too. We were very worried about risking our families' lives as well. And then the next picture is me getting my first COVID-19 vaccination. So I'll admit, when COVID first, was becoming a concern worldwide, and there was talk of ramping up and making a vaccine, I myself was a little hesitant, thinking, oh, I don't know that I want to be sort of forced or take a vaccine that's going to be so new, so experimental. But But then by the time December rolled around and the vaccine was available, I had firsthand seen so much devastation and death from COVID-19 that I think, I would have volunteered to get a vaccine in my eyeball at that point. We were just like so excited to have something that might help stem the tide of patients, sick patients and dying patients. And so that picture, I was a night shift, third night in a row. I'm kind of exhausted at this point, if you maybe can't tell from my face, but the vaccines became available at St. Francis Hospital there on December 18th. And I was really hoping to get a vaccine because they talked about how the emergency department staff and ICU staff would be, among the first to be available for vaccination. And I was really hoping to get a vaccine that on the 18th, the first day, because I was just so excited, counting down to be able to be vaccinated to protect myself and my family from this disease. And I showed up to my night shift, and they were already giving out like the last, vaccines. The other ER doctor on shift was getting like the last dose. And I literally was like in tears. I wanted to cry because I was so scared. Am I going to get vaccinated? Are we going to run out of vaccine? We didn't know when the next shipment was going to come in, anything like that. So the next day, I actually came to work a little early to try to make sure, and they had, set aside more vaccines for our emergency department staff, our night shift staff, and so that was my very first COVID vaccine, and I just felt a big sense of relief, like, okay, finally, there's something we can do about this and something we can do to help patients and ourselves. And then the last picture was actually just this spring at the Prairie and Potawatomi Health Center. So as him and Ed alluded, I had been working in the emergency department full-time, which had been my plan for the majority of my career. I love emergency medicine and wanted to spend most of my career in emergency medicine after I fulfilled my initial Indian Health Services obligation. I always expected that I would come back to Indian Health, to ResMed, as Dr. DeRoyne and I used to joke, that I would always come back to ResMed at some point in my career because I really enjoyed Indian Health as well, but had felt, the emergency department was where I would spend the bulk of my career. Well, then COVID changed the dynamic and changed that and changed all of us who worked on the front lines of healthcare. And so when the position came available last summer at the Prairie Health Center as the medical director, I was already looking for a way out of full-time emergency medicine, and, it felt like the right time. So I accepted that position and was very happy to come back to Indian Health, but much earlier than my career than I expected I would do. But there's a picture of me this spring giving a well child exam, one of my favorite things to do in the clinic, to see the new babies and to build relationships with the young parents and the families. One of the great things about being family medicine trained is we get to take care of patients through their whole entire life. And one of the reasons I included this picture, aside from the fact that it's a really cute baby, and I did get permission, that's actually my nephew, to use the picture, is that, we're still masking. I'm still masking. We don't have mandatory masking in the clinic anymore, but one of the things I do want to kind of touch on is COVID is still here, and it's, ramping up, and it is still affecting patients. So we want to still be cognizant of that, and we want to still protect our vulnerable populations. So, I'm still masking when I see our newborn babies, our elder patients who have comorbidities, our cancer patients, those things. I'm still doing everything I can to protect our patients from the spread of COVID. So, okay. So again, why are we even talking about COVID still, since we're all kind of sick of it? The biggest reason is it's still here, and just the staggering numbers of COVID-19. When I was pulling a little bit of data, since I felt, I was giving kind of a scientific talk, I should include a few facts in here. When I was pulling some data, the numbers of COVID cases and COVID deaths in the United States and worldwide is pretty staggering numbers. To actually see that in black and white was also sobering. So we need to still talk about COVID, and then again, it's still out there, and COVID numbers are on the rise. So COVID is still the 5th leading cause of death in the United States as of 2 weeks ago, per updated CDC data. Even in May, so mandated reporting of COVID cases, went away in May. So state health departments stopped with mandated reporting. But the last time that Kansas updated their KDHE COVID dashboard, the end of May, there were still 25 new cases, a week on average happening in Kansas then. And then now we're having our 3rd year of a COVID summer surge, which we've seen this for the last 3 summers now, according to the end of summer, early fall, of COVID ramping up. And part of that is people coming back together for, people traveling through the summer and then coming back together for school, for work, for whatever. So COVID numbers are on the rise for the first time in 2023, not nearly as severely as they have been the last 2 years, so that's really a good thing. And fortunately, most of the cases are milder. The hospitalization rate is significantly less, and the death rate is very, very low. So that's very positive, but just kind of a reminder, we don't want to forget about COVID. We don't want to ignore it. It's still there, and it has the potential to, mutate again and become stronger. So we want to kind of keep an eye on what's trending with COVID hospitalizations as well. And then the other reason we want to talk about, we specifically, the Native American communities and the Native American health communities want to keep talking about COVID is because of the effect it had on Indian country. And this is not new news. Already these are the same things that have been talked about all morning that everyone's aware of. The Native American communities were disproportionately affected by COVID-19. We were very hard hit, lost a lot of tribal members, really struggled with resources to help our patients. And so, I think it's something that we need to keep talking about to try to prevent that from happening in the future. God forbid there's another pandemic, but we want to do everything we can to be more prepared if this were to happen again. And some of the reasons the Native American population were harder hit, again, were already touched upon this morning. Lack of medical resources in Native communities. A lot of Native communities are very rural, and so there are not a lot of medical facilities, medical staff. People have to travel a long ways. Transportation, again, just a huge issue for our Native communities. A lot of them don't have available daily transportation. Multi-generational living, on the reservations. Everybody kind of lives together or stays with each other, and people tend to be a little migratory, the patient populations. I always kind of have to laugh and think I've seen some of the same patients at each of the 3 Indian health centers I've worked at now. When I worked in Oklahoma, when I worked at Kickapoo, and now at Prairie, I'm seeing some of the same patients. People kind of travel around. They stay with family and friends for different times throughout the year. Native communities are all about community, and so but that puts us at risk when there is a transmissible disease going through the country. And then also just the poverty and lack of sanitation and hygiene. We're fortunate here in Kansas. I feel like our reservations compared to other ones would be considered very wealthy. We have a lot of resources, and we do have funding and, good housing options for patients and things like that. But a lot of reservations do not have that. A lot of tribal lands are, very poverty stricken, and tons of Native American people don't even have running water, which is kind of crazy to think about, or electricity. So, basic sanitation and hygiene was an issue as well. And so all of these problems that contributed to why COVID-19 hit Indian country so hard kind of date back to, as alluded this morning, the U.S. government's failure to comply with their treaty obligations for our tribe with proper funding and proper resources. And then also just to kind of continue a little bit, no surprise to any of us that way before COVID-19 came around, the Indian Health Services was already kind of strained financially and staffing-wise, understaffed chronically, underfunded chronically. That second point about the Indian Health Services gets about $4,000 in funding a year for people served. On average, the national healthcare expenditure is about $9,700 per patient per year. So, we only get about half of what is spent on average in the rest of the country for healthcare for patients. And again, access to healthcare resources. There's fewer physicians, fewer nurses, fewer clinics in the Indian Health Services to try to take care of these people. So the pandemic just kind of exposed these weaknesses that Indian Health Service already had. As I was doing a little bit of review back, I remember the first year of the pandemic, the Indian Health Service getting a lot of press about the struggles on reservations and with tribal health centers. And one of the articles I was rereading from 2020 there in the New York Times, I thought this quote was just, so illuminating and just sobering and sad that, this is what some of our health centers were coming up against. They were asking for resources and literally getting body bags instead sent to them. Just like St. Francis Hospital in Topeka, though, many, facilities were asking for donations and relying on community members to try to make masks and make drapes and barriers and personal protective equipment because they couldn't get it from federal funding or the federal government. Also, a sobering way that Indian Health Services made history, in my opinion, was that the COVID-19 pandemic was the first time that the Doctors Without Borders ever served in the United States. So most people have heard of Doctors Without Borders. It's an organization to send medical personnel and resources to, hard-hit, poverty-stricken areas. So usually you hear of Doctors Without Borders of that going to Afghanistan, going to Africa, Ebola breakout, different things like that. And in 2020, Doctors Without Borders actually dispatched to the United States, the country that's supposed to have the greatest healthcare resources in the world, because of how hard hit the Native communities were, specifically the Navajo Nation. I know a lot of people are familiar with those statistics, but they were staggering. You know, the Navajo Nation had like a 50% infection rate of COVID-19, and the death rate, you know, they ended up being the epicenter, Navajo Nation ended up being the epicenter of COVID-19 with the highest per capita rates of COVID in the first year of the pandemic, way beyond even what New York City and the large metro areas in the US were experiencing, which is also, you know, staggering and shocking. And there was just such a loss of culture and people from those communities, you know, that can never be regained. And it's sad that that happened that way. Just a little updated COVID-19 cases. So this was, I pulled this from IHS website last week. So this was updated on August 16th, so just about a week ago, of just kind of the running tally they keep of COVID cases. Again, this may be not 100% accurate because COVID testing is not mandated reporting anymore. I think Indian Health Services is still trying to keep close tabs on numbers, but just still showing it's still occurring, still getting positive cases. The Oklahoma area where we reside, all of us, and practice healthcare, had the largest numbers, but we are also the highest population of Native Americans served in the Oklahoma IHS region. You know, we serve a population a little over 400,000 in Oklahoma and Kansas. So that's part of why our numbers were higher. If you look at kind of the percentage of positive, the Southwest is still a little bit higher than everybody else. Okay, and so one of the things that I think is most important as a healthcare worker and an ER physician to talk about with COVID-19 is what the effect COVID-19 had on our healthcare workforce. You know, our healthcare workforce is a precious resource, and I think people don't really understand that. They don't understand the time and money that it takes to train healthcare workers, you know, physicians, but even nurses, physician assistants, respiratory therapists. It takes a long time to train people to do these jobs. And then it takes a long time for people to be really good at those jobs. They need experience. They need years in the workforce, and they need experienced mentors to help train them even after school. That's such an important part of healthcare workforce training, and then, you know, ability to have the knowledge to take care of things. And COVID-19, you know, damaged that in so many ways. And I don't think the average American understands the fallout of that and understands the repercussions that are we're still seeing in the hospitals from how hard COVID-19 affected healthcare workers. And so one thing I want to talk about is something called moral injury. You know, but prior to COVID-19, the term burnout was used a lot in healthcare. And I would say it myself too, oh, well, we're burnt out. Everybody's burnt out. We're tired. And we were. You know, we were already a little bit understaffed across the board and overworked to begin with. Unfortunately, healthcare in the United States has become a business. And so majority of healthcare hospitals, healthcare clinics, and organizations are profit-driven anymore. That's one reason I was very happy to come back to the Indian Health Services, to step away from working in a, you know, money-centered, profit-driven environment, and to come back to a place where it's about patient care. Because that's what all of us who get into healthcare, that's what we want to do. You know, we want to take good care of people, and that's what we care about. Unfortunately, the business side of medicine has become about money. And so the people who are actually making decisions about funding and staffing, they don't really care, you know, if we provide good health care to patients or if we take good care of people. I mean, if we do, great, that's like a byproduct. What they care about is if we're making money. And that's created a sense of moral injury in work. And so this term, you know, originally came from the military, and I used to hesitate to make parallels between working in medicine and the military because I have such high respect for what our military servicemen and women sacrifice and go through. But through the COVID-19 pandemic, I realized there were a lot of similarities for both sectors. And so in the military, they had this, you know, they used the term moral injury. This was already kind of an expected term, and it's where people, the stress that you're placed upon when you want to do what you feel is the right thing to do, the best thing to do, what you're trained to do, but you can't because of some restriction. You know, in the military, it may be military rules or regulations, rules of engagement, orders from higher ups that prohibit that. And moral injury is also happening in healthcare. And the reason I think it's important to distinguish that from burnout is because burnout makes it sound like we as healthcare workers are not strong enough. You know, we're not taking good care of ourselves. We're not able to handle the pressures of the job we signed up to do. And that's not the case. You know, we're very strong. Healthcare workers are very strong people. We do so much for patients and sacrifice so much. But when the companies we work for, the corporations we work for, the hospitals we work for literally tie our hands in what we're able to do to help patients, it's hard for us to reconcile with that. We take that on personally because we feel a personal and moral obligation to our patients. And so during COVID-19, that was really exemplified. We were already feeling, betrayed by our employers, most of us, prior to the pandemic. And then the pandemic just made it even worse. And so many people have left the healthcare workforce because of the moral injury that is occurring. And I'll touch on this again in a minute. I don't think people understand that trickle-down effect of the amount of healthcare workers that have left. Just another quote about moral injury that I thought was important. From the beginning of the COVID-19 pandemic, while publicly healthcare workers were being, treated as heroes, which was fantastic, and we love seeing the appreciation and thanks from the general public. From the very beginning, by our employers, we were being asked to put ourselves at risk. Like moral injury began day one when our employers were like, you need to go to work with not enough personal protective equipment. You need to compromise yourself, your health, your safety to take care of patients. And on one hand, we don't mind doing that, and most of us willingly would have. And in the beginning, we were willing to do that. All of us healthcare workers were like, yes, we'll do whatever we need to do to take care of patients. But as the pandemic kind of went on, and there was funding and there were resources becoming available, but hospital systems were not utilizing them because financially, they realized they could make more money, actually. A lot of healthcare corporations made significant profits during the pandemic by keeping supplies and staffing very low in the emergency departments and in the ICU. Then it became very upsetting to us and troubling to all of us who worked in healthcare that, our employers didn't appear to value us at all. They didn't care what we were risking and what we were risking our families, putting our families at risk and ourselves. If all of the doctors and nurses were sick or dead because we weren't able to protect ourselves, then who is left to take care of the patients? And I don't think people understood that. And every one of us, we were doing everything we possibly could to keep our patients as safe as possible, and then ourselves and our family members as safe as possible. Many of us isolated ourselves from our families. I stayed in my basement most of the time. I tried not to spend a lot of time with my husband and my son. I would come home from work and immediately, strip my clothes down in the garage. Well, I would change at the hospital and kind of rinse off and wash off good. And then I would drive home and strip down in the garage and then come inside and hot shower myself before I would touch anybody. My son is, mom, why do you give me a hug? And I'm like, no, you can't touch me, running to the shower to wash. And then trying to isolate myself from my family as much as I could to protect them as well. And month after month of that, was very wearing on us too. And I know it was wearing on everybody in the country, but, I don't think, again, people really understood the toll it was taking on the healthcare workforce. So some of the continued moral injury of COVID-19 was the public shift from us being healthcare heroes to then sort of villains. Which that was very politicized. The agendas and the public things that were being spread about masking and vaccination and what you should follow, became very political in this country and not at all scientific based. So then there was a shift, in the general public from initial in the pandemic. People were like, okay, we'll do what we're supposed to do, and a lot of appreciation for healthcare workers. And then fairly quickly, within 6 months, it kind of changed to, we're not doing this anymore. This isn't necessary to mask. It's not necessary to isolate or quarantine, and sort of villainizing us healthcare workers for trying to do the right thing. I remember, people would find out I was a physician, or people knew I was a physician, and would just literally start, kind of attacking me about COVID, and COVID wasn't real, and this is all being made up, and masking doesn't help. And I'm thinking to myself, I am sacrificing literally everything. And working so hard, working extra shifts, because of course at this point, COVID has decimated the workforce just by healthcare workers getting sick as well. So all of us are stepping up and working extra shifts to fill when someone is sick and out. And yet, not that we want constant reward or praise, because, we don't, but at the same time, it was very demoralizing, very hurtful to have the public, treat us like we were part of some political agenda. Instead of doing everything we possibly could to save patients. And it was even more of a slap in the face when patients would have the audacity to show up in the emergency department sick and want our help and expertise, but then still deliberately refuse to wear their mask, deliberately put us at risk, but yet also demanding us to do everything we could to help them. So it was just it was the first time in my career I was angry with patients, like consistently angry with patients. I've always loved being a doctor and taking care of people. And during that time, I got very just angry and bitter towards patients, for being so selfish. Okay, so the worst moral injury of COVID-19 was, all of that was terrible, right? The lack of personal protective equipment, the lack of support from our administration in the hospitals, the lack of respect or appreciation from patients. But really the worst moral injury of COVID-19 was the patients themselves dying of COVID. It was not something I ever expected to see in my career in medicine, something I hope I don't ever have to live through again. Again, being a physician in America, I never thought I would go to work day after day after day and have patients dying day after day after day after day. I would have weeks where I'd had more patients die that week than I had in like an entire year before that. So just what seemed to be never-ending onslaught of sick patients and dying patients that we couldn't help. And that was such, just so hard on all of us, because we take an oath to do everything we can, and to have these patients come in who were very sick, and we knew there was nothing we could do for them. But we're still trying to give the patient some hope, but knowing, this is not going to work, this patient will die, was also very demoralizing and very paralyzing to our souls. I think all of us just kind of went into a bit of a black hole during that time, where we just couldn't really process that. This picture here is a picture of intubating a patient. So in the emergency department, we intubate patients a lot. It's where you put a patient on a ventilator to artificially breathe for them. Majority of the time, intubation is a life-saving thing that we do. So it's scary because in order to intubate a patient, we paralyze them, we sedate them and paralyze them. So as a patient, I would imagine it would be a scary thing to have done. And so always through my career, whenever I intubate a patient, I always try to be reassuring to the patient. I hold their hand, I talk to them before the process. This is what we're doing, you're gonna go to sleep, but this is gonna help us treat your pneumonia, your congestive heart failure, your whatever. Majority of the time, intubating a patient is life-saving. It's a life-saving thing to do. So throughout all of my career, I would intubate a patient, expecting that to be something that helped save their life. And most of the time it was. And so it was kind of easy to reassure patients. We're going to take good care of you. We're going to do everything we can for you. You're going to wake up in a few days and you're going to see your family again. It was easy to do that. But then COVID hit, and we were intubating patients that we knew were not going to wake up. And, again, day after day, these sick patients, and we didn't know how to treat them or what to do for them. So in the beginning, we thought, artificial ventilation was the best thing to do. So we were kind of universally intubating these patients, and these patients are scared, and they're already asking, am I going to die from this virus? Because nobody really knows, and there's no treatment. And that was hard to answer, hard to, you don't want to lie to patients, but you don't want to say, yes, you are going to die from this, and then asking patients to, let you intubate them because it was the only hope, only chance that we had. And so many of those patients, majority of those patients didn't come off the ventilators. They never woke up again. And as we realized that week after week, we realized what a hopeless thing this was we were doing for patients, but we didn't know what else to do. So it was, I think, again, it was a hard thing to do for people because you knew this patient was probably never going to wake up again. And when I let myself think about the pandemic, which I really haven't done a lot, I think about all of these patients, that I was the last voice in my crew, not, me specifically, but the nurses, the respiratory therapists, all of us working that day were the last faces, the last voices that these people saw and heard. And, I hope and pray that we gave people some peace before we sedated them to never wake up again. And, you would come back in to the hospital your next shift, hoping to hear that the patients you had intubated the week before were better, and they weren't. You were looking at the records from the ICU and they had died or they were still intubated, and you'd walk up to the ICU to follow up on your patients to check on them, and there was just room after room after room of patient hooked to machines in there by themselves, alone, isolated. We couldn't let the family come. We couldn't, as healthcare providers, we were trying to kind of minimize our time in exposing ourselves to COVID patients, so we didn't get sick as well. And it was just not something I ever thought I was going to have to ever do in my career in the United States, with all of our resources that we have here. And then there was a trickle-down effect too. Of course, everybody knew that the hospitals were overrun with COVID and that we didn't really have a good treatment for COVID, and patients were dying in high numbers of COVID. But what a lot of people don't realize is that because the hospitals were so full, there was not the capacity to treat what we normally could treat. So even more kind of salt in our wounds as healthcare workers, the things that we knew how to treat: heart attacks, strokes, brain bleeds, abdominal infections, sepsis, that we usually save lives all the time. It's bread and butter for us. We couldn't help because we had no resources left. We had no hospital rooms. We had no staff. I remember having patients with critical brain bleeds in the emergency department, and I could not transfer them anywhere because no hospital had staff anywhere. Emergency doctors, we were in a Facebook group of like 50,000 of us across the country, literally posting on Facebook, I have a patient with a brain bleed in Kansas and I need a hospital bed. Does anyone have a bed? Trying to see if we could fly a patient, 5 states away to get an ICU bed. And if we couldn't find a bed, these patients would just decline and die in the emergency department from things we normally could have treated. And so that was also, just extra hard on all of us. We felt like all of us, we took a lot of personal responsibility for COVID, but then the things that we normally could help and treat, all of us working in the emergency room and the ICUs took even more personal responsibility for that. How could I stand here and watch this patient with something that I know how to treat decline and die because I can't get them anywhere else but right here. So again, just such a painful experience for all of us that worked on the front lines of COVID-19. And I think a lot of healthcare workers, myself included, we've been not willing to talk about that. And I think it's time that we do talk about that. I think the general public needs to understand, kind of what we went through and the effect that it had on all of us. As I alluded to from the beginning, I planned to practice emergency medicine much longer in my career. And I just kind of got to a breaking point where I couldn't do it anymore. Not full-time. I still do part-time emergency medicine, which has still been great, but I couldn't full-time, day after day, show up and deal with these lack of resources and lack of ability to help patients after, with the skills that I knew we all had to do. So this is like the hardest time in my career so far, and all of us worked so hard during the pandemic. And then this picture, this is a picture that I'm afraid of. I don't even really like to look at it. I'm afraid of a time of going back to this, of being wrapped in plastic and not being able to touch my patients and being alone and isolated in the rooms with patients, not allowing their families to come back, not allowing other staff to come in to help us. This picture makes me scared. It literally gives me palpitations when I look at it, that I can't imagine this happening to our country and to our communities again. And so as much as I don't want to talk about COVID anymore because I want to move past it, and it was such a tough time for me and my fellow frontline healthcare workers, this is why it's important to still talk about it and still keep it in mind. I mean, the fact that we have a vaccine that has saved so many lives is a miracle, a literal miracle of modern science. To see the whole world mobilized to develop that was amazing. And I certainly am all about personal beliefs. I very much am. I was a chiropractor for a long time. I'm very holistic and natural, kind of less is more person. And if people don't want to vaccinate, I understand that. But the absolute sort of refusal of the general public to consider vaccination that would have slowed this pandemic down way sooner was just so hard to accept, so hard to see as a doctor after all that we had done and sacrificed for everybody. Okay, so to move on to a little bit happier stuff, sorry. There was some good, of course, that came out of COVID-19. Again, part of it was watching just the mass mobilization of resources to develop vaccines and to get help out to areas that needed help. And one thing I thought was actually amazing to kind of be on the outside, since I wasn't working in in-health services during the pandemic, and I was just kind of watching it as an outsider. I live in the community. I'm part of the community. My family's part of the community, but as a little bit of a more objective viewpoint, was watching the response that tribes, tribal health centers, tribal communities had to COVID-19. So in my opinion, the response of Native communities to COVID-19 was amazing. Everybody, it was so nice to see the rallying of tribal leaders to encourage patients to protect themselves and protect elders, and then to see community members follow that and do their best to abide by the recommendations of masking and distancing and isolating, and then to come out in mass force to get vaccinated, which I have a slide a little bit about the data with that, to watch the Native American communities do everything they could and be so proactive to minimize the effect of this and to spare lives was really amazing to see. And something that made me proud to be Native American, made me proud to be a part of the Indian Health Services in the past, and proud to be back in Indian Health Services again. The Indian Health Services is a small force, but it's mighty in a lot of ways, and it was really amazing to see that. I had a couple of statistics, like in Washington State, the Lumi Nation, set up field hospitals and testing sites way before any state officials had done. Again, the Navajo Nation, the tribal communities worked very quickly, also to set up command posts to deliver supplies to the rural communities, rural patients, and to provide vaccination and testing too. So, IHS really led Indian country, I should say, really led the forefront in showing the rest of the world how everybody could come together to do the right thing to minimize the spread of COVID and minimize the infection rate. And so again, I feel like the Indian Health Services were kind of the unsung heroes of the vaccines. The rate at which Native communities were vaccinated was significantly higher than the rest of the United States. And that was a pretty cool thing to see. I was really proud of that. The Prairie Health Center opening up vaccination to anybody who wanted to come, not only tribal members, was an amazing thing. Some of the reasons, Indian Health was able to work a little faster was the sovereignty and autonomy that tribal communities have. So they were able to identify easier and quicker, their resources, the communities that needed the most help, and get vaccines there quickly. Offering, vaccines in sort of unconventional sites, community gyms, boys and girls clubs, elder centers, going to people's homes to vaccinate, being willing to kind of make vaccination as accessible as possible was contributed to that. But it was a really, really cool thing to see, I think, and again, made me really proud of the Native American communities and Indian Health Services, how effective and how organized. It may not have felt it to those of you working in IHS, but compared to the rest of the world, you guys were very organized during the pandemic. So it was great to see that. And I couldn't resist, as I was Googling up some statistics, throwing this slide in here. I was hoping that maybe some of our other tribal members would be here, but this is a picture of the very first COVID-19 vaccine given at Prairie. That is our tribal chairman, Rupnick, and our venerable nurse, Laura Thackeray, who's been at the Prairie Health Center since I was a little kid and going to the Prairie Health Center. So I thought that was really appropriate for her to be, giving the first vaccine out. But this is also just a really great example of, I think, part of why Indian country and Native communities were so successful in vaccinating was here's a tribal leader, stepping up and saying, publicly, I'm masking, I'm getting my vaccine, I'm doing all of these things to protect our community. And that was great leadership. And I think that's part of why the community members were so willing to follow suit. The tribal leaders across the U.S. Sort of walked the walk and talked the talk. They did what they were asking patients to do, which we weren't really seeing that from our other officials, non-Indian officials, state and nationally. So, and I thought that, I had a quote from this, was a WIBW article that went out back in December 2020 when Chairman Rupnick got his vaccine. And the quote from him that the coronavirus pandemic was the greatest threat to the tribe in the past 70 years. So, and him publicly saying that ensuring that access to the vaccine was going to be paramount to the health and well-being of the tribal community. And I just thought that was great to have such vocal support from tribal leaders across the United States. Again, one more graph to make this a little more, scientific-y. So just a little updated again from August the 13th, kind of vaccine distribution by IHS area. So, vaccines are still being distributed, still being rolled out. We have seen a little dip in vaccine rates, at least here in Northeast Kansas. I know the overall numbers of people who got the first initial series of COVID are pretty high. The boostering has been a little bit low. We've had a little more trouble getting people to booster. but we're going to keep working on that. But vaccines are still being distributed and still becoming available for Indian Health Services. Kansas didn't fare too bad, about middle of the pack overall in vaccine rates across the country. So again, as of early August, about at least 65% of Kansans had had at least one vaccine. Sadly, less than 20% had had kind of a full series, including boosters, but one vaccine is better than none and still will provide protection. So we're happy about that. And just a quick blurb about what's changing for the COVID-19 vaccine in 2023. It did update. Last year, if you guys remember, the booster was a bivalent vaccine, which meant that it addressed 2 strains of COVID-19. This year, it's back to being a monovalent. Kind of data and tracking is showing that there's really only 1 strain of COVID that seems to be causing the spike in cases. And this strain is a little bit different than the previous strains. And so they're really targeting vaccination this fall for the new XBB strain of COVID-19 to try to protect people. Again, so far the cases we're seeing have, for the most part, been mild. Hospitalization rates are fairly low. And I think a lot of that is due to, previous immunity from the vaccines and then just kind of herd immunity now. COVID's been out long enough. A lot of people have had exposure, so. But we are encouraging boostering this fall now that there's a new strain of COVID-19 out there, because we do not want that strain to mutate and become stronger and ramp up and put us right back where we were. So, okay, that's kind of the end of my talk. Ending this with a quote that I read. Actually, I read this a few years ago. Dr. Michael Tutt is a Navajo endocrinologist, works in Tuba City, Arizona, and I had read an article of where he was interviewed. This is pre-pandemic even. Talking about Indian Health Services and, the importance of accessing medical care in Indian country. But this quote that I read of his in the article just has stuck with me for years now, and I sort of reflect back on it and think about it all the time, and I think it's a really great statement of what the Indian Health Services does for people. We're not just here to give medication to people. Of course, we are here to do that. But we're here to serve our patients in any way that we can, spiritually, emotionally. We want to be a place patients can come and get the help that they need. And there's a lot of us working really hard, especially here in Kansas. We're in unknown pockets of Kansas to provide the best health care, the best just care in general that we can to our Native communities in any way that we can. So I'm excited to be back with Indian Health Services. I was very thankful for the job opportunity, and I'm very excited to be back here today and thankful for this opportunity. And if there are any questions or grievances or heckling, I'll entertain that. Does anyone have any questions?
Exactly. Working in, no. Okay.
I appreciate that. Thank you. And hopefully this didn't come across as the need for any personal acknowledgement to me personally. I just feel it's important for people to kind of understand what we as frontline healthcare workers went through. I mean, everybody was working hard and stretched thin during the pandemic, but those of us who were, literally faced with life and death decision-making of the COVID patients day after day for 2.5 to 3 years, it was an incredible toll on us. And I think that our voices, it's time now for our voices to be heard and people to kind of understand what that experience was like for us. But thank you for that. I appreciate it.
I just have a question on the new vaccination coming up. Is there any timeline for when it would be starting to be offered?
Yes. Well, yeah, not really, kind of ish. So if we come back here, there at the bottom, kind of who is eligible and when is it going to be recommended. The CDC is supposed to be putting out some data in September, which is kind of a vague amount of time, hopefully early September, about when they're recommending vaccinating and kind of who they're recommending to be prioritized to vaccinate. So the new vaccine is coming out. I think we already have it at the clinic, or I thought we had received some, maybe not. We're getting ready to receive the shipments of the new vaccine. So it's arriving. We're just kind of awaiting the official CDC guidance of when to start administering it and who to target with it. So not really, we don't have official guidelines yet. CDC is holding out on us.
Okay, thank you. I also want to echo what Judy said. about, when you were speaking, to see those pictures too, I seemed like I was isolated at home a lot and watched TV, and it was just scary. It was so scary. And
Yeah.
it's kind of like when you were speaking, I was like, there should be something like a thank you for your service for during those days, because I also have a family member that's in that profession, and she basically moved to private practice after the COVID, because she said she had to get out of that hospital.
Yeah. Yeah. So many of us have left, acute care because of the risk COVID placed. And then again, just the emotional toll it took on us.
Hi, sorry. Is there any information that you might have on the coupling of the vaccine with like the flu vaccine, given the timing of distribution and the need for less jabs?
Yes. Yeah. Yeah. So, this year there are still two separate vaccines, COVID and flu. We were kind of hopeful they would actually be a combo vaccine. Then we could a lot of people will get the flu vaccine, but then we felt that would have been a great way to COVID booster people too. Not unknowingly, of course, but would have kind of slipped it in there. No, so as of right now, still two separate shots. We offer them to patients at the same time at our clinic. I think most clinics at this point are doing that. Last year I got both of mine at the same time. I've been encouraging our patients when they come back for their flu shots to, get their COVID booster at the same time. We're hopeful, and we kind of anticipate that down the road, there will be a combined COVID and flu vaccine just to make it easier for patients.
Hey, just reflecting back on if you were a person that partaked in a Moderna vaccine or a Pfizer vaccine or the protein-based vaccine, when you recommend it to your patients and they come in the next year, are you encouraging them to mix and match, or you're encouraging them to go by their prior experience if they're allergic to eggs or something, or whatever the journey is that they've started, or what is it that you're recommending?
Yeah, so again, we don't have really solid definitive guidelines on that. Personally, I think mixing actually has probably been a better thing for some patients, because each vaccine brand had some strengths and then each had some risk. So if the patient had like a true allergy to something that they could only receive Pfizer or only receive Moderna, then of course in that instance that's what we would recommend continuing with. But I think it's probably been beneficial to mix it up after the first initial vaccine series, and I've kind of encouraged patients to do that. It seems like people who have gotten both different brands of vaccine have maybe done a little better immunity. Okay, thank you guys for coming. I appreciate everyone listening to my talk, and let's go enjoy some good lunch. Thank you.
Dr. Pomkwe, Victor's COZAD has a gift. Thank you. We can't say thank you enough. That was emotional. It was. I've never seen it from that side, and never heard from somebody that experienced it from that side. I was on the other side, and seeing patients that I loved and getting sick and worried about them and all that stuff, and everything the knowledge that you carry now is so valuable. It's so important because we can all learn from that. So thank you for coming here today, sharing that, and I ask you to continue to share it. I know it's difficult, but thank you.
Thank you.
Let's give her a big round of applause.